Recording.
Welcome in, everyone. Welcome in to Tuesdays and Thursdays with Care Patrol. Thank you so much for being here. We appreciate you taking the time to be with us today. Welcome in. Others are joining us as we settle in and get our lunches in front of us and snacks. Hello, Charity. Thank you for being here today. Get your lunch in front of you, your bread buttered, your peas salted, get ready to go. I hope we have an engaging hour with you. Today, we'll be discussing the relationship between trauma and healthcare. And I think that this could be good for everyone, again, hopefully in a professional way, as well as possibly for some of you, as we'll discover, in a personal way. Welcome in, everyone. It's Tuesdays and Thursdays with Care Patrol. Today is relationship between trauma and health. And as folks are getting in and getting started and getting ready to eat or already eating, we will get started with our housekeeping. As you know, everyone who comes in is muted upon entering. So both those of you by cell phone and those of you by Zoom are muted upon entry. If you have questions, please use the chat room to ask them. No question is too simple. Please ask anything, even if it's unrelated to this topic. If someone else in the chat room brings up a solution or an idea that you find interesting, please engage with them. I hope that our goal here is for each of you to come away with something in addition to coming away with 1.0 contact hours if you're a social worker and 1.2 contact hours if you're a nurse. These will be paper certificates that are digital and emailed to you this evening after and only after and if you complete our evaluation at the close of this presentation, which is on SurveyMonkey. I'll give the address momentarily. Please try and answer all of the questions if you can. It's important to us to understand how we're doing and how to improve. If for some reason you're on the phone and fall off, please call back. I'll let you in. But otherwise, please know, all of you, that the boards of social work and nursing require that we be participants for 40 of the 55 minutes. Therefore, persons are not allowed to enter after 12:20 unless they've dropped the call. And so in the future, if you hope to participate, but it's 12:21, try and catch our recordings, which are available on our website, www.carepatrol.com. When you get to the website, you'll see in the upper right-hand corner, speak to an advisor. It will probably be me. If not, put in my zip code or your zip code in Alabama, or an Alabama zip code, and I'll come up rather. And then you can click on my advisor page, and on that page will be the recording of this session and others, so that you can listen. And if you'd like, get a recorded CD. This is a live CEU. Because we're using SurveyMonkey and we're coming to you live as if we were in person. I wish we were. Samantha asked, she attended the self-talk self-care CEU, did not complete the survey and tried to do it at 6, but would not submit. Yes, I will turn on that survey today for you so that you can complete it when you complete the other survey, and anyone else who may have missed that CEU survey from last session, it will be open for all of you to take again. Paper certificates are issued, evaluations due by 5 via SurveyMonkey. Please use the chat room. Thank you for using it, each of you who've done so. I hope others will do so. We are a senior care and placement company, meaning that we find families and seniors in crisis and try and help them understand the landscape of healthcare in front of them and what choices to make next. If those choices include providers that we are contracted with, like sitter services or assisted livings, then those providers pay our fee so that we remain free to those seniors and families in crisis. That's what we do. I hope that we can help you in some way in some day, but certainly enjoy having the ability to serve you today. Let's get started. I think most everyone is in. Again, it's Tuesdays and Thursdays with Care Patrol. Today's topic is trauma and its relationship to health care. So we have some objectives today. Our first is to define and list the effects, or two effects at least, of trauma. I think you'll have more than that at your disposal. We want to try and list some principles, or two principles rather, of trauma-informed care, which we'll discuss in greater detail. And we also want to provide, really throughout this presentation, the justification for you and your departments or clinics to institute trauma-informed care. So those are our objectives. Please make note of them. They'll be on the survey, and we'd like you to really be honest in addressing whether we cover these completely or correctly or not. Again, it helps us improve. And I appreciate y'all for taking the time to do these surveys. I know it's 5 minutes out of your life you'll never get back, but hopefully it's time that you'll consider in the long run well spent. So as we get into our relationship between trauma and healthcare, we'll define trauma for you. And while trauma could be what we often think of in healthcare as an injury that is, you know, a recent injury, an injury that brings us to the clinic, to the doctor, to wherever. And I have a little funny here. If there's 4 million workplace injuries every year, so play it safe, call in sick. I suggest that for y'all. But we will discuss later in the presentation maybe the need for providers to institute mental health days. And I think that is something that bears worthy discussion. You know, every disability is not visible. Some disabilities are trauma related. They are cognitive disabilities or emotional regulation disabilities. But generally, trauma is defined as an exposure to an event that's emotionally disturbing or life-threatening. Emotionally disturbing or life-threatening. And this event has lasting effects on the person who is experiencing trauma. And those lasting effects can curtail or inhibit or modify somehow their individual functioning and mental and cognitive ability, as well as their spiritual well-being. I think this is a fairly standard definition, one that we can all agree makes sense. What are the things that may cause trauma in persons? Well, the most prominent among them would be physical, sexual, and or emotional abuse. Childhood neglect, and many times this could be not simply neglect, but abandonment, or it could be that the child is living in the home with the person perpetrating these acts. It could be something like being a child in a home of a parent who has mental health issues that are uncontrolled and unmonitored, or who has drug abuse or substance abuse issues. There's chaos in that home for that child. There's no sense of structure. There's no sense of safety or normalcy. It could be the sudden unexplained separation from a loved one. Death could be a traumatic event for many people. It is a traumatic event for many people. I think it's more so for the young when their peers pass. Poverty is an experience that limits people in multiple ways, access to healthcare being one. But poverty would include things like folks who are underemployed or unable to be employed because of the effects of trauma on their lives. And it, I think, goes without saying, but let's say that any person born of color, of mixed race, anyone who identifies as gay or bisexual or transgender, these people experience trauma from birth and continually experience trauma daily. And this affects their cognition, their emotional regulation, and their ability to cope. I think we think of trauma most often as PTSD. And it may be that we have PTSD or trauma-related illness because of our experience with, for example, the tragedy of 9/11, or with the various wars that have occurred in each of our lifetimes, including the current one in Ukraine. Yes, these do deliver traumatic experiences and health effects, but they are not the only ones. And they are not, I don't think, the most prominent of those. So for those of you just joining us, it's Tuesdays and Thursdays with Care Patrol. We're discussing how trauma can affect our relationship with healthcare. And we're just getting into experiences that may be traumatic. And I must point out at this point that many of these experiences occur during the formative years of childhood and even further back into infancy. And so many of the things that we'll address relate directly back to childhood trauma. And that's because trauma in children affects their neurobiology and their physical development. We know that the first 1,000 days of a child's life are great periods, critical periods of brain development. And that if a child during those 1,000 days is experiencing traumatic events, they develop what scientists call toxic stress. This is an emotional and or physical response that is for someone who experiences prolonged traumatic adversity without adequate support, and that's important, without adequate support. And trauma negatively impacts the areas in the brain responsible for cognition, such as short-term memory and emotional regulation. And this is through the body's stress reaction. I know this on a personal level. A family member of mine experienced great trauma in childhood. I have noticed that this person sometimes has difficulty in certain instances with making a decision, with processing information or stimuli, with emotionally regulating their behavior. For example, the person I'm thinking of may have uncontrollable bouts of crying. This is a natural, if not normal, occurrence with folks who experience trauma in childhood. Exposure to the stress hormones that are brought about by this exposure play a key role in each of us who normally experience danger or threatening experiences or activities or associations. Whereas the person who's experienced trauma may not have a good line defining those two, because after all, the thing that has traumatic that has happened to them has broken that social contract and barrier of normalcy for them. And it is now forever for many of them broken. We have others joining us. Thank you all for joining. We're discussing the effects of trauma on healthcare. We've been defining trauma and listing some of the effects and how it affects us as we grow. And so the question within might persist, why would trauma impact some folks greater than others? If two persons have the same traumatic single event happen, and one has a lifetime of experiences incorporating maladaptive behavior in trying to cope with this, and the other has an otherwise supportive relationship with a family or their family, research shows that that is a protective factor for the person, for the developing brain of the child, and it can decrease the impacts of those traumatic events that are otherwise unchecked in the person who's experienced this and yet has no significant safe support system. So these are sort of a broad brush of the apparent effects of trauma, and ones that you might effectively and quickly notice when evaluating a patient. If they complain, for example, of trouble sleeping, if their answers indicate that they are unengaged, that nothing matters, that they are flat effect, as they say in psychiatry, if they come in and they are generally and often worried about things that maybe don't rise to the level of worry, and whether or not they do, they worry a great deal, or alternately, they may feel guilty without knowing why. If they express this, I think it's time to maybe probe a little deeper. They may say they feel like they have to stay busy, or, and this would be apparent perhaps with some, not with others, they may be using maladaptive behaviors like excessive eating or usage of drugs or alcohol, prescription medications, or, and this is a self-check for those of you listening, they may be throwing themselves into work to the neglect of other areas in their life. Good afternoon, Belinda. Thank you for being here. So maladaptive behaviors, I think we can surmise what this means. It's a coping mechanism that folks develop who have experienced trauma, in which they hope to alleviate their emotional pain, or perhaps even physical pain that they feel as a result of this trauma. A maladaptive behavior would be any behavior that might seek to provide temporary respite or relief from the event, but on the whole may compound the effects of that event long term. Drug and alcohol use would be the most obvious, but you may find that you have patients who isolate. This could be a maladaptive behavior. And of course, those who present with chronic diseases bear investigation. What are the effects of trauma? Well, there are many. The chart here shows but one, and it lists adverse childhood experiences, which we'll discuss in greater detail momentarily. But in general, you can see in the chart that the risk for heart disease increased with each exposure to a traumatic event in childhood. So that should a child have 7 or 8 exposures to a traumatic event, their risk factor for developing heart disease later in life nearly triples. And this is sobering. 62% of us in the US have at least one adverse childhood experience. That would be 6 in 10 of you on the phone. 25% have 3 or more adverse childhood experiences that may be going untreated and unaddressed. That's 1 in 4 of you on this phone call. Trauma leads to cortisol spikes. We know that cortisol regulates our digestion, our immune system, our reproductive systems, and our pituitary and growth. And we know that if there are repeated cortisol spikes, that these make us susceptible more so to chronic conditions in healthcare later in life. The more exposure, the greater risk. And basic neuroscience indicates, however, again, that if we can provide a supportive and caring relationship, even for the child with 7 or 8 adverse childhood experiences, we can significantly reduce the effects during their childhood development and decrease the health concerns that will present for them later in life. In fact, there was a study in which children were removed from traumatic homes and placed into foster homes where there was supportive and loving care. And in each case, the children's IQs increased over time, and they were more likely to be able to form healthy emotional attachment relationships. We can prevent many of the effects of trauma if we can address children early. And if we can't, what might we expect to see from them? Alcoholism and liver disease, obesity, autoimmune diseases, migraines, depression and anxiety, suicide attempts, health-related quality of life issues that may prevent them from work, for example, illicit drug use, ischemic heart disease, lung cancer, COPD, use of nicotine products of all sorts, drugs and alcohol, unintended pregnancies, promiscuous sexual behavior and a risk for STDs, and if it weren't insult enough, the possibility for intimate partner violence later in life. These are the effects of trauma. And what might we expect then of these children who experience these effects? They are, as we would say, wired differently. Brains that are normally adapted to deal with instances of threatening behavior or danger because they're under nearly constant stress, struggle to respond in those same instances in knowing, is this a dangerous situation? Is this person threatening? They lose the ability to make those decisions. And the resulting mental health conditions can lead to problems that are lifelong, that transpose through school and into work and into relationships and on and on. Most adult trauma survivors struggle with depression or emotional regulation issues, bouts of crying. How does this affect you as the clinician? Well, what it does is it undermines the ability of the adult who experienced childhood trauma to form a bond or relationship with you, the caregiver. This is important because it is you, the caregiver, that seeks their good health and well-being, and they are not engaged nor compliant in that if they cannot form some sort of trusting relationship with you. There was a landmark study that Kaiser Permanente performed with the Centers for Disease Control. And it was simply a study of adverse childhood experiences. They simply wanted to calculate what these were, and they formed or created this worksheet that I've posted here in the Zoom. And for those of you by phone, you will receive the presentation by email this evening with your certificate. And also these presentations are recorded on our website at carepatrol.com, and you can see this worksheet. The potentialities for adverse childhood experiences are pretty significant and pretty dire. And the questions are, for those of you that may not be able to see them, did a parent or other adult in the household often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? How many of you could answer that question? That's one adverse childhood experience. They get more grim, and I won't read further, but they can have deleterious effects on any age person, including the child. We've covered this. And compared to persons with no adverse childhood experiences, persons with 2 or more, according to the Kaiser study, are 2 times more likely to use nicotine products or smoke. They're 2.5 times more likely to be promiscuous and engage in unprotected sex, which is unsafe, and have STDs. And they're 4 times more likely to develop COPD later in life. People with 2 or more adverse childhood experiences, as compared to those with none, are 7 times more likely to be alcoholics. They're 10 times as likely to have injected street drugs like heroin. And they're 12 times as likely to commit suicide. There is a link here for those of you when you get the presentation. It's the Anna Institute, and it is a Word document that allows you to compute your score, if you so choose, and to determine your adverse childhood experience score. And then using that, the Anna Institute provides a lot of help and guidance in what to do next. So we addressed that trauma impacts relationships. This is why this topic is important in healthcare. It's important to you, it's important to your patient, and it affects the delivery of healthcare in every way to the person who has had a series of traumatic events and experiences in life. That person, and entering your clinic or office or ER.
I found this on the web for Hey series of traumatic event.
I'm sorry, my phone was listening to me. Siri has never spoken to me in my life until just now. So a person may feel unsafe in the clinic because they feel unsafe in life. They may feel somehow betrayed by you, the healthcare giver, or by life in general. And they may have real difficulty trusting you. And this can lead to them to have heightened emotions, issues with emotional regulation, anger or aggression towards you, or they may fall silent and get trapped in the cycle of shame that they so often coexist in, where it remains and leaves them isolated. So if this can impact the bond between you, the provider, and the patient, and impact their engagement in their care, how can we address this? We'll address this later in the presentation. But we know that people that begin to see supportive acts can begin to develop a resilience and can begin to form healthy attachments in certain instances with certain people. And we think that this will lead you to want to become more versed in trauma-informed approaches to care, like relational healing. This is when the person is asked to relate the traumatic event over and over and over, noting the emotions and physical sensations that arise. This is led with a therapist. The therapist has them repeat these events consistently, and at the conclusion of this repetition, the therapist then begins introducing topics that either challenge those ideas or are otherwise positive and joyful and life-affirming And this apparently over time has some ability for that person to reroute that trauma response into a more appropriate and healthy response. There's trauma-specific treatments like that or others that help patients begin to process their experiences and begin healing. And this may be, of course, a long process for them, but the sooner we start, the healthier person we find. And Gail Thrasher relates to those of you on the phone. There's a Holmes and Ra, or is it Rahe, forgive me, stress scale, which is about stressful events for adults. And the address for that is mindtools.com. And you can search that scale on that. Thank you, Gail, for offering that. I so often ask that folks feel like this is a safe place to offer ideas and ask questions. And thank you, Gail, for doing so. So first off, let's talk about trauma in the sense that we first addressed. Someone presents with an injury that's traumatic. What do we do for that person? We help them to know to take these steps. One, acknowledge their feelings. Don't minimize, don't trivialize, don't dismiss. It's not just a broken leg. It impacts you in a significant way and will for the next 6 weeks. Don't minimize it. This is a traumatic event. Find someone to share your feelings with. It should be, in this case, you, the clinician who is asking about this. Ask about this. And this would be an instance of asking not what's wrong with you, which is in a sense a sort of aggressive accusatory statement, and asking instead an empathetic statement, which is, what happened to you? You were innocent in this. What happened to you? That can develop trust. Of course, they want to avoid numbing their responses with alcohol, or in this case, prescription painkillers. They don't want to catastrophize about the future. The world is not coming to an end, but it is significant that they've broken their leg. But let's stay in the present. How do we address getting out of this clinic, for one, and then going about the rest of our lives? And then don't dive into the avoidant activity that seems so appealing, that provides a simple respite, like immersing yourself in work. And again, I challenge you on the phone. If you are one of the 6 in 10 here who have one adverse childhood experience, or you're one of the 1 in 4 who've had 3 or more, are you immersing yourself in work? Are you immersing yourself in work? Are you putting yourself at risk? And that's my soap. Control what you can and let other things abide. There is, some of you may know, the serenity prayer. God grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. Control the things that you can control. And then self-care. Eat, sleep, rest, exercise, engage in life. These are things, steps to help minimize an immediate trauma, a recent trauma, a trauma that is still in experience. And yet we know that we need a deeper trauma-informed approach to care than simply this. Trauma-informed care seeks to realize the widespread impact of trauma. I think we've made that point. And understand the paths for recovery of that. Recognize the signs and symptoms, which we've addressed to some degree, of trauma in patients and families. Next, we will hopefully begin to integrate knowledge about trauma into the policies, procedures, and practices in our clinic, or if not in our clinic or office or hospital, in ourselves. And the thing that we want to do, unless we are a therapist engaging in a therapeutic exercise, we want to avoid re-traumatizing the person. Well, we may ask what happened to you. We should not ask them to go into detail to any degree. Instead, we should ask them present-based questions like, how does this make you feel now? How do you cope with this? Things of that nature. And we're shifting the focus again from what's wrong with you to what happened to you. So the core principles then of trauma-informed care are trustworthiness and transparency, peer support, meaning your peers, as well as the peers of the patient, humility and responsiveness on your part, and humility here would be taken to mean taking into account traumatic experiences like poverty on your patient. Have humility. Try and place yourself in their shoes and understand the difficulty with whatever it is that's presenting for them to ameliorate. Empower your patients. Safety is a core principle of trauma-informed care. In other words, is this person a harm to themselves or to others? And collaboration, both with the patient and with the other clinicians and even non-clinicians within our office. And here is the CEU code word for the day. Please make note that the code word is also the password for the test. So code word, password means same thing. Trauma, that's a capital T, R-A-U-M-A. Trauma is today's code word. You have to use the code word to complete the survey to get your certificate. So we've addressed the principles of trauma-informed care, but what are the practices in an organization to institute trauma-informed care? Well, our hope would be that one or more of you would engage today your senior leadership in a discussion about implementing trauma-informed care in your clinic or in your hospital or in your care setting, whatever it is. And that would require us to or them, or all of us, all of you rather, to reorient the culture of the healthcare setting to address trauma when people enter. You'd want to lead and communicate with others about the need for trauma-informed care. And you'd have to make sure as an organization that all staff were informed. For example, many people who have experienced adverse childhood events and have developed trauma and have issues with emotional regulation also have issues around safety and threat. And it might be, for example, very important that they were greeted in a warm and welcoming and friendly and non-threatening way. And then that each person who they passed along the line did the same. In this case, for example, as you place a person in a setting, you might ask to make sure that it is a comfortable temperature, because many times people that have had adverse trauma in life have physical sensations that they can't control. Temperature regulation is one of them. They may find that the music is too loud, and it is a problem for them, as loud sounds can often be. It may be that they need to know for their own safety and anxiety where the exit is, and that may need to be pointed out by the person that guides them to the office or to the examination room. So these are the things we want to train all of our staff. We want to create a safe physical and emotional environment. For example, we want the exits well lit and noted. We want the noise level low. We want welcoming language, healthy boundaries, and consistent schedules in terms of follow-up and in terms of what the patient is left to do. Many folks who've had adverse childhood experience trauma have difficulty with setting boundaries. And so providing them with very close parameters and schedules is very helpful for them. It allows them to better cope and engage in their self-care with you. So what are the clinical practices for trauma-informed care? Well, those would be that we want to address the impact on the individual of the trauma. We want to involve the patient. We want to screen the patient. And we want to be certain that in doing so, we have trained our staff the proper screening techniques. And we want to engage our referral sources and partner organizations in certain instances to understand how they may better relate to this patient who has trauma-induced issues. So we also want to care for one another and for the staff who will be providing this care to others. So we want to provide training such as this one just to raise awareness. And mind you, these CEUs are not intended to go deep into the information. Instead, they're intended to present you with a broad brush overview of the information so that you can then discover more on your own if you wish. So what we want to do then here in addressing this with others is also address it with ourselves. Physician, heal thyself. Provide training around stress to everyone in your office. Provide during that training the opportunity for your staff to explore their own adverse childhood experiences, which they may not even have yet addressed. The ACE score that we've discussed earlier might be an opportunity here with your staff. And we want to support reflective supervision so that when you have either stand-up meetings or individual meetings with either your supervisor or those persons with whom you supervise, you want to have a little bit of a mental health wellness check-in around any events that may have triggered their own trauma through interaction with patient trauma. And then we want to encourage activity. This may be walking your dog when you get off work today. It may be yoga if you're so inclined. It may be riding your bike. It could be anything. But physical activity, we know, increases our general spiritual well-being. And I mentioned this at the beginning of our presentation, but I think it's important that we allow staff to take mental health days. And I think these might be in addition to or in place of health days. We take those, and it is without shame and with, the well wishes of others. But if we were to take a mental health day, would we be greeted in the same way as we are if we have the flu? If we just couldn't do it today? Allow the staff to do so. And then once you've implemented this within yourself and within your organization and its practices and policies and procedures, when you've worked with your peer groups to make certain that they are also well, then you would want to, as you bring in new staff, make sure that they are already trauma informed. And you would do this through a behavioral interview, much like the one on the screen, in which you would ask them to describe an event in which a trauma, it was present in a patient interaction, how they handled that, what they did, and what the results were. And you can very quickly determine if they have empathy and humility and the ability to put themselves in others' shoes. And so when we do trauma screening, then we want to know when and how to do so. And we want to know, basically, the treatment should guide whether or not we screen. If we're treating someone's bunion, it's unlikely that that's trauma related. Whereas if we're treating someone's COPD, there's a decent chance that it is. In the end, regardless, the screening should benefit the patient. If you cannot provide justification prior to screening that it will benefit the patient to be screened and then be treated, then do not screen. Do not rescreen. Again, we mentioned earlier, we do not want for the trauma victim to have to relive and re-experience an ancient trauma in the present moment. And we always want to provide training. So in trauma-specific approaches that staff might take either for themselves or for the benefit of others, I've included the breathing meditation here that we did 2 sessions ago. Breath meditation can do wonders for slowing the heartbeat and the mind and the emotions and settle you during the day when you may be having some sort of adverse experience related to childhood or other trauma. There are other, much more clinical ways to approach trauma-specific approaches, one of which we've discussed already, prolonged exposure therapy. Excuse my dogs. The other is with prolonged exposure therapy, as we're recounting those adverse experiences over and over and over, and listening to the therapist is engaging in 2 things with that person. One is imaginal, which is just that. Imagine this event in great detail, describe it, describe how you felt, what you were feeling, your physical sensations. The other is an in vivo retelling, which is from the beginning retelling good things. There's eye movement desensitization. That's a hard word. Desensitization and reprocessing, or EMDR. And this is a little controversial. It was developed by a therapist who noticed that when her patients were discussing trauma in their lives, that they made a series of rapid eye movements. And she reckoned that those rapid eye movements may have something to do with the trauma and the way the brain was processing the trauma, so that she believed and hypothesized, and many people use this, in fact, that by redirecting the eyes of the trauma victim while retelling their story, by moving her hand or clasping it or clapping or making a noise or otherwise somehow providing some regulation, some beat, that the person could reprocess this in a sense, in a detached manner that would allow them to better adapt. There's another organization that's often mentioned when you look at trauma-informed care, because there is so much maladaptive behavior involved, including alcohol use, that the Seeking Safety, which is SAMHSA, which is a society for mental health issues, basically, around abuse. The hypothesis there is clear. If you can address someone's issues with drug or alcohol, and at the same time address their issues with the precursors to that drug and alcohol use, the childhood trauma, that you can in effect, have a very positive effect on both the cessation of the alcohol usage and the healing of the trauma in the person. And then there are select child models. These are all, I think, fairly straightforward. One clearly would be simple adult child therapy. One would be ARC, attachment, self-regulation, and competency. This is both an overarching training and an approach to children that allows them to begin to self-regulate their emotional behavior. And then there's trauma-focused cognitive behavioral therapy. We discussed cognitive behavioral therapy last week, and we understand the tenets of that, that we write out or list all of the various negative images and thoughts that occur. We challenge those, and then we replace those with declaratory statements about our ability in each of those areas versus our inability. And so you can see that that would be a very easily adapted approach to assisting someone with trauma and adverse childhood experience. And that is our short CEU for the day. I'm sorry that we didn't run longer, but on the other hand, I hope that you all will have 5 minutes to freshen up before you go back into your workday. Thank you so much for being here. Again, we're a senior care referral and placement agency. We are paid by providers, not by families or patients. And we'd love to help anyone in crisis that has a need or a concern or a question around long-term care or home care. You'll receive your certificates this evening. It says tomorrow, but it will be this evening. The CEU code word or password again is trauma, capital TRAUMA. You have to complete this by 5 generally, although I am opening the self-care today for those who missed 5 o'clock last week. I'll return the surveys today, and someone has asked to put the link in the chat. I will do that. Well, I won't do that. I'm sorry. I can't copy and paste. I'll say the link for those of you on the phone, and perhaps those of you who can't cut and paste can type in this while I say it. It is https://www.surveymonkey.com/r/7 uppercase N as in Nancy, 3, uppercase T as in Tom, 8, uppercase D as in David, 2. So again, for those of you on the phone or keying this in, the SurveyMonkey link is https://www.surveymonkey.com/r/7 uppercase N as in Nancy, 3, uppercase T as in Tom, 8, uppercase D as in David, 2. Thank you so much, as always. Thank you for what you do. I know that many of you work in settings that have nothing to do with elder care or senior care, and yet you continue to listen in and benefit me and others with your comments. And I so appreciate you for that. And I appreciate for what you do for those people that are in your charge. I know that you put them first. And I know that you're here today for that reason. And I thank you for it. Thank you so much, everyone. We're a little early, but I'll end today's session. If you have questions or concerns, please email me sbarnes, that's BARNES @carepatrol.com. Again, my thanks to you for all you do. and for joining us in this session today. Please go out and have a great day. Stay warm and dry. And see you next time.